You have about 10 seconds. 68 years old. Crushing pressure under the sternum, diaphoretic, and his pressure is falling while his heart races to keep up. Something is failing right now. And the real question is not what the diagnosis is called. The question is what you do first and how you knew. By the end of this, you will be able to look at a monitor, a lab, or a rhythm strip and reason your way to the answer, even for a patient you have never seen in a question bank. This is cardiology. All of it. Let's build it from the ground up. Chapter 1, The Pump. Every cardiac disease you will ever study is a problem somewhere on this loop. Blood returns from the body, deoxygenated, blue, into the right atrium, down through the tricuspid valve into the right ventricle, out the pulmonic valve to the lungs. It picks up oxygen, turns red, and comes back through the pulmonary veins into the left atrium, down through the mitral valve into the left ventricle, the ficus chamber, because it has the whole body to push against, out the aortic valve, and around again. Hold on to one thing from that loop. The right side sends blood to the lungs. The left side sends it to the body. So, when the right side fails, blood backs up into the body. When the left side fails, it backs up into the lungs. That single sentence will answer more heart failure questions than anything else in this video. Left equals lungs. Both start with L. Now the electricity. The SA node fires, your natural pacemaker, 60 to 100 times a minute. The signal spreads across both atria and they contract. It pauses at the AV node, and that pause is what lets the ventricles fill. Then down the bundle of His, out the bundle branches, into the Purkinje fibers, and the ventricles squeeze. Remember the order. The electrical event comes first, and the mechanical event follows. Which means it is entirely possible to have electricity with no squeeze. Keep that in your pocket. Electricity without a squeeze. We will come back for it in Chapter 6. And it is one of the most misunderstood things in all of nursing school. Here is the equation that runs the rest of this video. Cardiac output is how much blood the heart moves in 1 minute. It equals heart rate times stroke volume. Normal is roughly 4 to 8 liters a minute. Stroke volume, the amount ejected per beat, depends on 3 things, and only 3. Preload, afterload, and contractility. Every cardiac drug in existence is an arrow pointing at one of those 3. Preload is the volume in the ventricle right before it squeezes, the stretch on the muscle. More volume returning means more stretch, and up to a point. More stretch means a stronger squeeze. Think of a rubber band. Pull it further, it snaps back harder. Now overstretch it, and it stops snapping back at all. That failure point is heart failure, and we will watch it happen in Chapter 4. Afterload is the resistance the ventricle has to push against to get blood out the door. Mostly that is the pressure in the arteries. High blood pressure means high afterload. The heart is pushing against a heavier door every single beat, about 100,000 times a day. Do that for years and the muscle thickens, then stiffens, then fails. That is the entire reason we treat hypertension in a patient who feels completely fine. Contractility is the strength of the squeeze itself, independent of how full it is. This is the one that drops after a heart attack because dead muscle does not contract. And it is the one that drugs like digoxin and dobutamine are designed to raise. So how do we actually measure the squeeze in a real patient? Ejection fraction. It is the percentage of the blood in the ventricle that actually leaves on each beat. Normal is roughly 55 to 70%. Notice that even a healthy heart never empties. That is expected. 40% or below, and we call it a reduced ejection fraction. That is the number on the echo report, and it decides which kind of heart failure your patient has. One more number, and this one gets missed constantly. Blood pressure has 2 values, but organs are not perfused by the systolic. They are perfused by the mean arterial pressure, the average across the whole cardiac cycle. Because the heart spends more time relaxed than contracting, that means sits closer to the diastolic. 65 is the number to remember. Below 65, the kidneys and the brain are not being adequately perfused, no matter what the systolic says. Let's use it. Your patient's cardiac output has dropped. Their heart rate is 118, so the rate is not the problem, it is the compensation. Which means stroke volume fell. Pause here. Which of the 3 would you check first, and why? Preload. Because the fastest, most common, and most correctable reason stroke volume drops is that there is not enough volume coming back. Assess volume status before you reach for anything that changes the squeeze. Tachycardia is usually the compensation, not the problem. Ask what it is compensating for. That is the whole foundation. For numbers: rate, preload, afterload, contractility. Ejection fraction tells you about the squeeze. Mean arterial pressure tells you about the perfusion. From here on, every disease we cover is one of these going wrong. And every drug is an arrow pointed at one of them. Screenshot this one. You will want it for chapters 4, 9, and 10. Go back to our patient. Heart rate 132. Pressure 82/48, and that is a mean arterial pressure of 59. He is underperfused, and his heart rate is already maxed out trying to fix it, so his stroke volume has collapsed. The question is which of the three failed. But first, there is a hormonal system running in the background of every one of these patients, and if you do not know it, half of cardiac pharmacology is going to feel like memorization. Chapter 2: The Pressure Loop. The kidneys are the body's pressure sensors. When kidney perfusion drops, from blood loss, from dehydration, from a failing heart, the kidney does not know why. It only knows the pressure is low, and it responds the same way every time. It releases renin. Renin converts angiotensinogen, which the liver is constantly making, into angiotensin 1. Angiotensin 1 is inactive. It passes through the lungs, where an enzyme called ACE turns it into angiotensin 2. And angiotensin 2 does two powerful things. First, it constricts arteries directly, which raises pressure immediately. Second, it tells the adrenal gland to release aldosterone, and aldosterone tells the kidney to hold on to sodium. And water follows sodium. More volume, more pressure. It is an elegant system for surviving a hemorrhage. It is a disaster when the underlying problem is a failing heart. Now watch what happens when we put drugs on that diagram. An ACE inhibitor, anything ending in pril, blocks the enzyme in the lungs. No angiotensin 2 gets made, so no vasoconstriction and no aldosterone. An ARB, anything ending in sartan, lets angiotensin 2 get made but blocks the receptor it acts on. Same endpoint, different door. Aldosterone antagonists like spironolactone block the last step. And an ARNI boosts the natriuretic peptides that oppose the whole system. For classes, one pathway. If you know where each one sits, you do not have to memorize any of them. One consequence you have to know. A CE also breaks down bradykinin. Block a CE, bradykinin accumulates, and about 1 in 10 patients develops a dry, persistent cough. That cough is not an allergy. It is a predictable class effect, and the move is to switch to an ARB, which does not touch the enzyme. And the one you cannot miss. Angioedema. Swelling of the lips, tongue, or airway is an emergency, and that patient does not get another ACE inhibitor ever again. Which brings us to hypertension itself. It is called the silent killer for a literal reason. The pressure damages arteries for years without producing a single symptom. High pressure injures the endothelium, the smooth inner lining of the vessel, and injured endothelium is where plaque begins. Meanwhile, the left ventricle, pushing against that afterload every beat, thickens. A thick ventricle is a stiff ventricle, and a stiff ventricle does not fill well. So untreated hypertension gives you coronary disease and heart failure at the same time, from opposite directions. Now the distinction that gets tested. 2 patients, both with a pressure over 200 systolic. The first has no symptoms. No chest pain, no vision change, no confusion, no drop in urine output. That is hypertensive urgency, and it is lowered over hours to days with oral medication. The second has a pounding headache, blurred vision, and new confusion. That is hypertensive emergency, and it is an ICU problem with an IV drip. Same number, completely different patients. The number is not what makes it an emergency, the organ damage is. And here is the part students find counterintuitive. In a hypertensive emergency, you do not normalize the pressure, you lower the mean arterial pressure by no more than about 25% in the first hour. Why? Because a brain that has been living at a mean of 140 has reset its autoregulation to that pressure. Drop it to normal suddenly and you do not rescue that brain, you infarct it. Controlled, gradual, monitored. Pause and pick. For patients, all with a systolic over 200, which one do you see first? Patient A, headache. Patient B, new confusion. Patient C, a nosebleed. Patient D, missed 2 doses. The answer is patient B, the one with new confusion. Headache, nosebleed, and a missed dose are all concerning, but new confusion is a neurologic change. And a neurologic change in the setting of severe hypertension means the brain is being injured right now. New confusion is an organ damage cue, and that is the word that converts urgency into emergency. Because the same endothelium hypertension has been injuring for years is exactly where our patient's problem started. Chapter 3: When the artery closes. Start with a healthy coronary artery. Smooth lining, open lumen, blood moving freely to the muscle. Now add decades of injury. High pressure, high cholesterol, nicotine, high glucose. Lipids get into the vessel wall, immune cells follow. A plaque forms and over years it grows and narrows the lumen. Here is the critical part. A stable plaque with a fit cap can narrow that artery by 70%, and the patient may only notice it when they exert themselves. But when the cap ruptures, and rupture is what plaques do, the body sees exposed collagen and does what it is designed to do. Platelets swarm the site. A clot forms. And in minutes, a partially narrowed artery becomes a completely occluded one. Every symptom from here comes from one imbalance. The muscle needs more oxygen than the artery is delivering. That is it. Which is why exertion provokes it, exertion raises demand. And why rest and nitroglycerin relieve it. One lowers demand, the other raises supply. Ischemia is a math problem. Lower demand or raise supply. Now the 4 names, in order of severity. Stable angina, predictable chest pain with exertion, relieved by rest or nitroglycerin in about 5 minutes, no permanent damage. Unstable angina, the pain now comes at rest, or it is new, or it is worse than usual, and it does not reliably resolve. NSTEMI, muscle has actually died, but the artery is partially open, so the ECG does not show ST elevation. STEMI, complete occlusion, full thickness injury, and ST elevation on the ECG. Same disease, 4 points along it. Here is the part worth screenshotting. You separate all 4 with exactly 2 questions. Question 1, did muscle die? Troponin answers that. Troponin is a protein inside heart muscle cells. If it is in the blood, cells broke open. Angina, stable or unstable, has a negative troponin. Both infarctions have a positive one. Question 2, is the artery completely occluded? The ECG answers that. ST elevation means full thickness, complete occlusion. No elevation means partial. 2 questions, for diagnoses, that is the whole algorithm. One caution on troponin that shows up constantly. It takes about 3 to 4 hours after injury before it is detectable, peaks around 24 hours, and stays elevated for up to 2 weeks. Which means a single negative troponin in a patient who started having chest pain 30 minutes ago tells you almost nothing. That is why we draw them serially. 1 negative troponin at 30 minutes rules out nothing. The classic presentation is crushing substernal pressure radiating to the jaw or left arm, with sweating, nausea, and a sense of doom. But you must know the atypical picture, because that is where patients get missed. Women, older adults, and people with diabetes may present with fatigue, shortness of breath, indigestion, or back pain, and no chest pain at all. Diabetic neuropathy can blunt the pain entirely. A silent heart attack is still a heart attack. Chest pain walks in. What happens and why? Oxygen only if the saturation is low. A 12-lead ECG within 10 minutes, because everything downstream depends on whether there is ST elevation. Aspirin, chewed, because you want it absorbed in minutes. It stops more platelets from joining the clot. IV access and continuous monitoring, because the most common cause of death in the first hour is a lethal dysrhythmia, not the infarct itself. Nitroglycerin for the pain. Morphine if pain persists, and notice it is last, not first. Now the trap. Nitroglycerin works by dilating veins, which drops preload. Usually, that is exactly what you want. But an inferior wall heart attack often involves the right ventricle, and a right ventricle that is infarcted is completely dependent on preload to fill. Give nitroglycerin to that patient and you take away the one thing keeping their output up. The pressure can crash. So before nitro, check the blood pressure and know which wall is involved. If the systolic is below 90, or it is an inferior or right ventricular infarct, that is a hold and question, not an administer. Never give nitroglycerin without checking the blood pressure first. For ASTEMI, the goal is to open the artery, and time is muscle. The preferred route is percutaneous coronary intervention, a catheter to the blockage, a balloon to open it, a stent to hold it. The target is door to balloon within 90 minutes. If the facility cannot do that in time, thrombolytics are given instead, with a door to needle target of 30 minutes. And thrombolytics come with a screening question. Any active bleeding, recent surgery, recent stroke, or known bleeding disorder is a contraindication, because the drug does not distinguish between the clot in the coronary and a clot anywhere else. After the infarct, watch for what the dead muscle causes. Dysrhythmias, most common, and most likely in the first hours. Heart failure, because contractility just dropped. Cardiogenic shock, if enough muscle is gone. Pericarditis, days later, from the inflamed surface. And the rare, catastrophic ones. Papillary muscle rupture causing sudden severe mitral regurgitation, and ventricular wall rupture. A new murmur after a heart attack is never a minor finding. Pause. Your patient with an inferior wall heart attack reports chest pain, 8 out of 10. The provider has ordered sublingual nitroglycerin. The blood pressure is 86/52. What do you do? You hold the dose and contact the provider. Not because you are refusing an order, but because this is a preload-dependent infarct with a systolic already below 90, and nitroglycerin would drop it further. The strongest wrong answer here is give it and monitor closely. Monitoring does not prevent the crash, it only lets you watch it. Questioning an order is a nursing action, not a refusal. So, our patient, 12 lead shows ST elevation in the anterior leads. Troponin is positive. That is an anterior STEMI. And the anterior wall is fed by the left anterior descending artery, which supplies a large part of the left ventricle. He goes to the cath lab and the artery is opened. He survives. But a significant piece of his left ventricle is now scar, and scar does not contract. His ejection fraction, which was 60% last year, is now 35, which changes everything about how his body handles fluid. Chapter 4. When the pump fails. Heart failure does not mean the heart stopped. It means the heart cannot move enough blood forward to meet the body's demand. And when blood doesn't move forward, it does the only other thing available to it. It backs up. Every single sign and symptom of heart failure comes from one of those two facts. Not enough forward gives you fatigue, weakness, and poor perfusion. Too much backward gives you congestion. Learn it that way, and you never have to memorize a symptom list again. Left-sided failure. The left ventricle can't eject well, so blood stays behind. Pressure rises in the left ventricle. It backs into the left atrium, and from the left atrium into the pulmonary veins. Now watch the physics. As pressure rises in the pulmonary capillaries, the hydrostatic pressure pushing outward finally exceeds the pressure holding fluid in. Fluid crosses into the alveoli, the air sacs. And air sacs, full of fluid, cannot exchange oxygen. So the patient becomes short of breath. You listen and you hear crackles at the bases first, because of gravity. They can't lie flat, because lying flat pushes even more fluid into the lungs. That's orthopnea. They wake at night gasping, paroxysmal nocturnal dyspnea. The oxygen saturation falls. And in severe cases the sputum is pink and frothy, because that fluid is plasma with red cells in it. Every one of those findings is the same fluid, in the same place. Now the same logic, opposite side. The right ventricle can't eject into the lungs, so blood backs up into the right atrium, into the vena cava and out into the body's veins. Where does that show up? The jugular veins distend. That's JVD. The liver engorges and becomes tender. Fluid collects in the abdomen as ascites, and it pools in the dependent tissues, the ankles and feet in someone who walks, the sacrum in someone who's been in bed. The patient gains weight fast because that is retained fluid. 2 to 3 pounds in a day is fluid, not fat. There is no way to eat 3 pounds of tissue overnight. Put them side by side, and it becomes almost impossible to confuse. Left failure is a lung picture. Right failure is a body picture. And here's the connection students miss. The most common cause of right-sided failure is left-sided failure. The left side backs up into the lungs, pulmonary pressure rises, and eventually the right ventricle is pushing against that raised pressure, and it fails too. Which is why most of your patients have findings from both columns. There are 2 mechanical ways to fail, and the ejection fraction tells you which. Reduced ejection fraction, HFrEF, the ventricle is dilated and weak, it can't squeeze. Ejection fraction 40% or below, preserved ejection fraction, HFpEF. The ventricle is thick and stiff, it squeezes fine, but it can't relax and fill, so even though the percentage ejected looks normal, the actual volume is small. This is the one that follows years of high blood pressure. Same congestion, same symptoms, different mechanism. And that is why the drug that helps one may not help the other. Remember RAAS? Here is where it becomes the enemy. The failing heart delivers less blood to the kidneys. The kidney reads that as low volume, and it activates RAAS, vasoconstriction and fluid retention. But the problem was never low volume. So now the failing heart has more afterload to push against, and more volume to handle. The sympathetic system does the same thing. It raises the heart rate, which shortens filling time, and raises oxygen demand in a heart that is already struggling. The body's rescue response is actively making the failure worse. That is exactly why we block both systems. ACE inhibitors and ARBs for RAAS, beta blockers for the sympathetic drive. So bring back the frame and place the drugs. Diuretics pull off volume, that's preload. ACE inhibitors, ARBs, and ARNIs reduce vasoconstriction, that's afterload. Plus they block the remodeling. Beta blockers slow the rate and protect the muscle long term. Digoxin increases the strength of the squeeze, that's contractility. Aldosterone antagonists block the final retention step. Every heart failure drug you will ever be asked about is one of those 5 arrows. And 2 cautions. Beta blockers are for chronic, stable heart failure. You do not start one in a patient who is acutely decompensating and wet. 3 things confirm it. BNP, B-type natriuretic peptide, is released when the ventricle is stretched. So a high BNP tells you the ventricle is under volume stress, and it is most useful for one specific question. Is this shortness of breath coming from the heart or from the lungs? It is not a standalone diagnosis. The echocardiogram gives you the ejection fraction and shows you the valves. That is how you tell HFrEF from HFpEF, and the chest X-ray shows congestion and an enlarged heart. When heart failure decompensates acutely, you are looking at flash pulmonary edema. Severe shortness of breath, the patient sitting bolt upright, anxious, crackles throughout, saturation falling, sometimes pink frothy sputum. This is an airway and breathing emergency. Sit them upright, high Fowler's, legs dependent if tolerated, because that reduces the blood returning to an already overloaded heart. Oxygen. An IV loop diuretic to pull volume off, nitrates to reduce preload if the blood pressure supports it. And notice what the position is doing. It is a nursing intervention that changes preload. It is physiology, not comfort. Discharge teaching is where heart failure is actually managed, and it is heavily tested. Daily weight. Same time, same scale, same amount of clothing, first thing in the morning after voiding. Call for a gain of 2 to 3 pounds in a day or 5 in a week. Restrict sodium, because sodium holds water. Take the medications even when feeling well. And report worsening shortness of breath, needing more pillows to sleep or new swelling. Needing an extra pillow to breathe at night is not a comfort preference. It is a reported symptom of worsening congestion. Pause, and select all that apply. Which of these findings point to left-sided heart failure? Crackles, jugular venous distension, orthopnea, dependent edema, pink frothy sputum, and an enlarged, tender liver. Crackles, orthopnea, and pink frothy sputum, all three are fluid in the lungs, so all three are left-sided. Jugular venous distension, dependent edema, and an enlarged liver are systemic congestion, which is the right side. And here is the reasoning shortcut for any question like this. Before you even look at the options, ask yourself which direction the blood is backing up, lungs or body. Then sort. Our patient, 6 weeks after his heart attack. Ejection fraction 35%. He has gained 4 pounds since Monday, he is sleeping on 2 pillows, and there are crackles at both bases. That is left-sided heart failure from the muscle he lost, exactly what we just built. He is started on a loop diuretic, an ACE inhibitor, and eventually a beta blocker. And then, on day 3, the monitor changes. His rhythm is no longer regular, which means it is time for the skill most nursing students say they never really learned, and the one that shows up on the exam as a picture, not a paragraph. Chapter 5. Reading the rhythm. Before any specific rhythm, you need a method, and it is 5 questions asked in the same order every time. 1. What is the rate? Under 60, 60 to 100, or over 100. 2. Is it regular? Are the R waves evenly spaced? 3. Is there a P wave before every QRS? 4. Is the PR interval normal, that is, 0.12 to 0.20 seconds? 5. Is the QRS narrow or wide? Narrow is under 0.12. And that last one tells you something. Narrow means the impulse came from above the ventricles. Wide means it started in the ventricle itself. Narrow is usually less dangerous. Wide gets your attention. Normal sinus rhythm. Rate 60 to 100, regular, a P wave before every QRS, PR interval normal, QRS narrow. This is your reference. Every abnormal rhythm is a specific deviation from this picture, so the better you know this one, the faster everything else becomes obvious. Change only the rate and you get the 2 sinus variants. Sinus bradycardia, under 60. Normal in a conditioned athlete or during sleep, but a problem when it is caused by a beta blocker, digoxin toxicity, or rising pressure in the brain, and a bigger problem when it is symptomatic. Sinus tachycardia, over 100. And this is the one students get wrong. Sinus tach is almost never the problem. It is the answer to a question. Pain, fever, low volume, low oxygen, anxiety, blood loss. Do not treat the number. Find what it is compensating for. Atrial fibrillation. Instead of the S, a node firing once in an organized way, multiple sites in the atria are firing chaotically, hundreds of times a minute. The atria do not contract, they quiver. The AV node blocks most of those impulses, but the ones that get through arrive at random intervals. So the hallmark is irregularly irregular, with no identifiable P waves, just a wavy baseline. Now the consequence that matters more than the rhythm itself. Atria that quiver instead of contracting, let blood pool. Pooled blood clots. That clot can travel to the brain, which is why atrial fibrillation is a leading cause of stroke, and why anticoagulation is central to managing it, often more important than the rhythm. 3 management goals. Control the rate, with beta blockers, diltiazem, or digoxin. Control the rhythm, with antiarrhythmics or cardioversion. And anticoagulate. And there is a trap in that middle one. If a patient has been in atrial fibrillation for more than 48 hours, you do not just cardiovert them. There may already be a clot in that atrium. And restoring an organized contraction would launch it, so either anticoagulate for about 3 weeks first, or image the atrium with a transesophageal echo to confirm there is no clot. Atrial flutter is the organized version of the same idea. One reentrant circuit in the atrium, looping around 250 to 350 beats a minute. That produces a sawtooth pattern instead of a chaotic baseline. The flutter waves are identical to each other, which is the tell. The AV node blocks a fixed proportion, so the ventricular response is often regular. Same clot risk, same anticoagulation logic. Flutter, sawtooth, waves all identical. Fibrillation, chaotic, no two alike. Supraventricular tachycardia. Fast, usually 150 to 250, regular, narrow QRS. And the P waves are often buried in the preceding T wave because there is no time between beats. The problem with a rate that fast is not the rate itself, it is that filling time disappears. No filling time means low stroke volume, and low stroke volume means low cardiac output. If the patient is stable, vagal maneuvers first, bearing down, which slows conduction at the AV node. If that fails, adenosine, rapid push followed immediately by a flush, because its half-life is only a few seconds. Warn the patient. Adenosine briefly stops the heart, and they will feel it. If the patient is unstable, synchronized cardioversion. Premature ventricular contractions. An irritable spot in the ventricle fires early. Because it starts in the ventricle, the impulse does not use the fast pathway, so the QRS is wide and bizarre, and there is no P wave in front of it. Occasional PVCs are extremely common and often benign. What makes them worrying is frequency and pattern. More than 6 a minute, 2 in a row, 3 or more in a row, which is by definition ventricular tachycardia, or multiple different shapes. And always ask why. Low potassium, low magnesium, low oxygen, caffeine, and digoxin toxicity all provoke them. Which brings up the reframe that makes electrolytes finally click. Do not memorize them as chemistry, read them as rhythm causes. High potassium, peaked T waves, then a widening QRS, heading toward arrest. Low potassium, flattened T waves and U waves, and it potentiates digoxin toxicity. Low magnesium, the classic setup for torsades. Low calcium, a prolonged QT, which is itself the setup for torsades. When a rhythm changes, check the electrolytes. Pause. Run the method on this strip. Rate, regularity, P waves, PR, and QRS width. Rate around 110. Irregularly irregular. No identifiable P waves, a wavy baseline instead. Narrow QRS. That is atrial fibrillation with a rapid ventricular response. And notice, you did not need to recognize it on sight, you derived it. That is the difference between studying rhythms and knowing them. That is our patient strip. New atrial fibrillation after a heart attack, in a heart that is already failing, which is common, because a dilated, stretched atrium is an irritable atrium. He is rate-controlled and anticoagulated, and he does well. For a while. Then, on the 5th night, the monitor alarms again. And this time, the QRS complexes are wide. Everything so far has been survivable. What comes next is not, unless someone recognizes it in seconds. Chapter 6. The Lethal Rhythms. Before any specific rhythm, there is one question that governs every response in this chapter, and it is not what is the rhythm. It is, does this patient have a pulse, and are they stable? The rhythm tells you the name. The pulse tells you what to do. Assess the patient, not the monitor. Ventricular tachycardia. 3 or more consecutive ventricular beats over 100. Wide QRS, regular, no visible P waves. The ventricle has taken over. Now the fork. If the patient has a pulse and is stable, awake, talking, adequate pressure, you have time. Antiarrhythmics like amiodarone and prepare for synchronized cardioversion. If the patient has a pulse but is unstable, hypotensive, altered, chest pain, synchronized cardioversion now. And if there is no pulse, this is a cardiac arrest. Start CPR and defibrillate. Same rhythm, 3 different responses. The pulse check is the branch. Ventricular fibrillation. The ventricles are not contracting at all, they are quivering, chaotically, with no organized complexes. Nothing is being ejected. There is no cardiac output and there is no pulse. This patient is clinically dead right now. The only thing that reverses it is defibrillation, an unsynchronized shock that depolarizes the entire heart at once so the SA node can retake control. High-quality CPR between shocks, epinephrine, and defibrillate. Every minute without defibrillation drops survival substantially. This is the rhythm where speed is the entire intervention. This is the distinction that gets missed most. Defibrillation is unsynchronized. It delivers energy immediately, whenever the operator presses the button. It is for ventricular fibrillation and pulseless ventricular tachycardia, rhythms with no pulse. Synchronized cardioversion times the shock to land on the R wave, deliberately avoiding the T wave, because a shock on the T wave can throw the patient into ventricular fibrillation. Cardioversion is for unstable rhythms that still have a pulse. So, no pulse, defibrillate, pulse but unstable, synchronize. Torsade de pointe, twisting of the points. It is a specific form of polymorphic ventricular tachycardia, where the complexes appear to spiral around the baseline, getting taller and shorter in a repeating pattern. It arises from a prolonged QT interval, and the treatment is the thing to lock in. Intravenous magnesium sulfate, even when the magnesium level is normal. So the question becomes, what prolongs the QT? Low magnesium, low potassium, low calcium, and a long list of medications. Torsade, twists, give mag. V blocks are about the relationship between the P wave and the QRS. First degree, every P still conducts, but slowly, the PR interval is over 0.20, consistently, nothing is dropped. Second degree type 1, Wenckebach, the PR interval gets progressively longer, until one P wave does not conduct and a QRS is dropped. Then the cycle restarts. Second degree type 2, the PR stays constant, and then a beat is suddenly dropped without warning. This one is more dangerous. Third degree, complete block, nothing gets through, the atria fire at their rate, and the ventricles fire at their own escape rate, completely independently. This is the one that needs a pacemaker. Longer, drop, that is a Wenckebach. And now the payoff from Chapter 1. Asystole is no electrical activity at all, a flat line. There is nothing to shock. A defibrillator resets electrical chaos, it cannot create electricity where there is none. So asystole gets CPR and epinephrine, not a shock. Pulseless electrical activity is the one that confuses everyone. The monitor shows an organized rhythm, it may look almost normal, but the patient has no pulse. Remember, electrical activity comes first, mechanical contraction follows. In PEA, the electricity is firing and the muscle is not answering. It is not shockable either. The treatment is CPR, epinephrine, and finding the reversible cause, the H's and T's. Only two shockable rhythms in all of cardiac arrest: VFib and pulseless V-tach. Everything else is CPR, epinephrine, and cause. Pause and put these in order. You walk into the room. The patient is unresponsive, and the monitor shows ventricular fibrillation. What is the sequence? Check responsiveness and call for help, including the code team and the defibrillator. Start compressions immediately, do not wait for the machine to arrive. Attach the defibrillator when it is there. Defibrillate. Resume compressions immediately after the shock without pausing to reassess the rhythm, because that pause costs perfusion pressure. Compressions do not wait for equipment. Our patient. Wide, complex tachycardia, but he has a pulse, and he is talking to you, though he is pale, and his pressure is soft. Pulse present, unstable. That is synchronized cardioversion, and it works. Afterward the team checks his labs, and his potassium is 3.1, his magnesium is low. He has been on a loop diuretic for 6 weeks, the rhythm was not random. It was electrolytes, which is what it usually is. He is replaced and stabilized. Now, the heart is not the only thing in the cardiovascular system. Chapter 7. Vessels and Sacs. 2 patients, both with a leg problem, completely opposite conditions and opposite nursing care. Peripheral arterial disease, blood cannot get down into the leg, so the leg is starved. Cool, pale, hairless, shiny thin skin, weak or absent pulses. The pain comes with walking, because walking raises demand, and it is relieved by rest. Ulcers are deep and punched out on the toes. And, crucially, elevating the leg makes it worse, because you are asking already inadequate flow to fight gravity. These patients hang the leg down. Venous insufficiency is the opposite. Blood cannot get back up out of the leg, so the leg is congested. Warm, swollen, brownish discoloration, pulses present. The ache worsens with standing and improves with elevation. Ulcers are shallow and weepy around the inner ankle. These patients elevate and wear compression. Arterial dangles. venous elevates. Get those backwards and you make the patient worse. Deep vein thrombosis. A clot in a deep vein, usually in the leg, favored by Virchow's triad. Stasis, vessel injury, and hypercoagulability, so immobility, surgery, pregnancy, and cancer are all risks. The presentation is unilateral, swelling, warmth, redness, and calf tenderness in one leg but not the other. Unilateral is the tell. Bilateral swelling is more likely a volume or cardiac problem. And the reason it matters is what happens if it breaks loose. It travels to the lungs. Sudden shortness of breath and pleuritic chest pain in a patient with a DVT is a pulmonary embolism until proven otherwise. Now the aorta. An abdominal aortic aneurysm is a bulge, the wall weakens and balloons outward. It is usually silent, sometimes found as a pulsating mass near the navel. And the nursing rule. Do not palpate deeply, because aggressive palpation of a known aneurysm risks rupture. If it ruptures, you get sudden, severe back or abdominal pain. With hypotension, a surgical emergency. An aortic dissection is different. The inner layer tears, and blood forces its way between the layers, splitting them apart. The pain is sudden, severe, tearing or ripping, and it classically radiates to the back. A key finding is a difference in blood pressure between the two arms. Management is aggressive blood pressure and heart rate control. The sac around the heart. Pericarditis is inflammation of that sac. The pain is sharp and pleuritic. It worsens with a deep breath and when lying flat. And it improves when the patient sits up and leans forward. That positional relief is the classic tell. You may hear a friction rub. Now, inflammation produces fluid. If enough fluid collects in that sac, it compresses the heart from the outside, and the heart cannot fill. That is cardiac tamponade. It gives you Beck's triad. Hypotension because output falls. Jugular venous distension because blood cannot get in. And muffled heart sounds because there is fluid between the heart and your stethoscope. The intervention is pericardiocentesis. Drain the fluid and the heart can fill again. Infective endocarditis is infection of the valves and inner lining. Bacteria seed onto a valve and grow vegetations. Suspect it with fever plus a new murmur. That pairing is the core clue. The peripheral findings are classic exam material. Splinter hemorrhages under the nails, painful Osler nodes on the fingertips, painless Janeway lesions on the palms and soles, and Roth spots in the retina. Fragments can break off and travel anywhere, including the brain. Osler is ouch, painful. Janeway is painless. Valve disease reduces to two problems. Stenosis, the valve is narrowed and will not open properly, so the chamber behind it has to generate more force, and it hypertrophies. Regurgitation, the valve will not close properly, so blood leaks backward, and the chamber behind it handles extra volume, so it dilates. Stenosis causes pressure overload and thick walls. Regurgitation causes volume overload and big chambers. Aortic stenosis is the one to know by name because of its triad. Syncope, angina, and shortness of breath on exertion. Stenosis thickens. Regurgitation stretches. 3. Cardiomyopathies. Dilated, the chambers enlarge and the walls thin, so contraction is weak. This behaves like reduced ejection fraction heart failure. Hypertrophic, the muscle thickens, often the septum, which can obstruct outflow. This is the one associated with sudden cardiac death in young athletes, and the teaching is to avoid dehydration and strenuous competition. Restrictive, the walls become stiff and cannot relax, so filling is impaired. This behaves like preserved ejection fraction heart failure. Pause for a bow tie. Your post-heart attack patient develops hypotension, jugular venous distension, and muffled heart sounds. Choose the condition, 2 actions to take, and 2 parameters to monitor. Condition is cardiac tamponade. That is Beck's triad. The actions: prepare for pericardiocentesis and notify the provider immediately. The parameters to monitor: blood pressure and heart sounds, because if the effusion is reaccumulating, the pressure falls again and the sounds muffle again. And note where this came from. A post-heart attack patient. The inflamed pericardium after an infarct is exactly how you get here. Every pair in that chapter is tested by contrast, not in isolation. Arterial against venous, aneurysm against dissection, pericarditis against tamponade. If you can only remember one thing from each pair, remember the nursing action that differs, because that is where the question lives. Chapter 8. Procedures and Devices. Cardiac catheterization. A catheter is threaded from an access site, usually the radial or femoral artery, up to the coronary arteries, and contrast dye is injected so the blockages become visible. If a lesion is found, it is treated in the same procedure. A balloon inflates to compress the plaque, and a stent is placed to hold the vessel open. Beforehand, you are asking about allergies, specifically iodine and shellfish, because of the contrast, checking kidney function, since contrast is hard on the kidneys, and marking the distal pulses so you have a baseline to compare against afterward. Afterward, you are watching an arterial puncture site in an anticoagulated patient, so bleeding is the concern. Keep the affected leg straight and ahead of the bed low for a femoral site. Assess the site for bleeding or a hematoma, and check the distal pulses, color, temperature, and sensation against the baseline you marked. Encourage fluids to clear the contrast. Monitor for chest pain, because chest pain after a stent can mean the vessel re-occluded, and the finding you escalate immediately. Sudden severe back or flank pain with hypotension, which suggests a retroperitoneal bleed, where the patient can lose a large volume with nothing visible outside. Coronary artery bypass grafting. When the disease is too extensive for stenting, a vessel is harvested, commonly the internal mammary artery or the saphenous vein, and grafted to route blood around the blockage. The sternum is divided to get there and wired back together, so afterward you are managing a healing sternum on top of a cardiac recovery. Sternal precautions. No lifting more than about 10 pounds, no pushing or pulling to get out of a chair, and splint the chest with a pillow when coughing, because we still want them coughing and deep breathing to prevent pneumonia. Watch chest tube output, and report a sudden increase or a sudden stop. A pacemaker treats a heart that is too slow or is not conducting. Symptomatic bradycardia, or a complete heart block. It delivers a small impulse to make the heart beat. On the monitor you see a pacing spike immediately before the complex it generated. Failure to capture is when there is a spike but no complex follows. The impulse fired and the muscle did not respond. And that must be reported. Teaching. Check the pulse daily and report a rate below the set rate. Avoid strong electromagnetic fields. Carry the device card. And in the first weeks, avoid raising the arm on the device side above the shoulder so the leads can settle. An ICD is a different device with a different job. A pacemaker treats slow, an ICD treats lethal fast. It monitors continuously and delivers a shock if it detects ventricular tachycardia or fibrillation. Most modern devices do both. Teaching. If the device fires once and the patient feels well afterward, they notify the provider. If it fires repeatedly, that is emergency care now. Someone touching the patient during a discharge may feel a tingle but is not harmed. Pacemaker pushes slow hearts faster. ICD interrupts deadly fast ones. You will see hemodynamic numbers in critical care, and they are less intimidating once you map them onto Chapter 1. Central venous pressure reflects preload on the right side. Pulmonary capillary wedge pressure reflects preload on the left side. Systemic vascular resistance reflects afterload. Cardiac output measures the forward flow. You do not need to memorize the ranges to reason about them. You need to know which of the 4 variables each one is reporting on. Pause. 2 hours after a femoral cardiac catheterization, your patient reports new severe back pain. Blood pressure has dropped from 128/74 to 92/58. The dressing is dry and intact. What is the priority action? Notify the provider immediately and prepare for further assessment. This is a suspected retroperitoneal bleed. And here is the reasoning that makes this hard. The dressing being dry is not reassuring. It is the detail that makes it dangerous. Because the blood is going backward into a space where you cannot see it. Falling pressure with new back pain after a femoral puncture is a bleed regardless of what the dressing looks like, hardware, procedures, and the nursing that surrounds them. But there is one more thing that can happen to a heart like our patient's, and it is the one where the intuitive answer is the wrong answer. Chapter 9. Shock and Deterioration. Shock is not a blood pressure. Shock is inadequate tissue perfusion. Cells are not getting the oxygen they need. Blood pressure can still look acceptable early because the body compensates hard. Heart rate rises, vessels constrict, and pressure is maintained, which means the earliest signs of shock are not hypotension, they are tachycardia, restlessness, or new confusion from poor brain perfusion, cool clammy skin, and falling urine output as the kidneys are sacrificed to protect the brain and heart. By the time the pressure falls, compensation has already failed. Recognize the compensation and you are minutes ahead. Now all of them at once, because on the exam they appear as a differential. Think of it as a pump, a tank, and pipes. Hypovolemic shock, the tank is empty. Hemorrhage, dehydration, burns. Fill the tank. Cardiogenic shock, the pump has failed, most often after a large heart attack. The tank is full, the pump cannot move it, and the lungs get wet. Distributive shock, the pipes have dilated so the same volume no longer fills the space. Septic shock is the common one, and in early sepsis the skin is often warm, the opposite of the others. Neurogenic shock is distributive too, and it is the one with bradycardia instead of tachycardia. And obstructive shock, something is physically blocking flow. Tamponade, tension pneumothorax, massive pulmonary embolism. Full tank, working pump, blocked path. Cardiogenic shock specifically. The heart has lost enough functional muscle that it cannot maintain output, most often after a large heart attack. So you see the signs of low forward flow, hypotension, tachycardia, cool, clammy skin, altered mental status, low urine output, and at the same time, signs of backward congestion, because the blood that is not being ejected has to go somewhere. Crackles. Jugular venous distension. The combination is the fingerprint. A patient who is underperfused and fluid overloaded at the same time. And here is the single most important reasoning point in this chapter. A hypotensive patient triggers a reflex in almost every student. Give fluid. In hypovolemic shock, that reflex is correct, the tank is empty. In cardiogenic shock, it is the wrong answer and it can be a fatal one, the tank is already full. The pump cannot move what is in it. Add more volume and you push more fluid into lungs that are already wet. What this patient needs is help with the pump. Inotropes like dobutamine to improve contractility, sometimes a vasopressor like norepinephrine to hold the pressure up, treatment of the underlying infarct, and often mechanical support. This is exactly why the exam gives you crackles and jugular venous distension in the stem. Those two findings are there to tell you the tank is full. Two categories that get blurred together. Inotropes change contractility, how hard the heart squeezes. Dobutamine is the classic one, and it is what you reach for when the problem is a weak pump. Vasopressors change afterload, they constrict vessels to raise the mean arterial pressure. Norepinephrine is the common first-line vasopressor. They are not interchangeable because they are pointed at different variables on the frame we built in Chapter 1. Inotrope, squeeze. Vasopressor, squeeze the vessels. Pause and read the trend. Same patient, for sets of vitals over 6 hours. Heart rate climbing from 88 to 131. Pressure drifting down from 124/78 to 86/54. Urine output falling from 60 to 10. And mental status going from alert to confused. What is happening? Every parameter is moving in the same direction. Rising rate, falling pressure, falling output, declining mentation. Any single one could be explained away. Together, and moving the same way, they are compensated shock progressing toward decompensation. The patient did not become critical at the fourth set of vitals. They became critical around the second, and the fourth is just when it became obvious. One abnormal value is a data point. For moving the same direction is a trajectory. So, our patient, look at what you now know that you did not at the start. He came in with an anterior STEMI from a ruptured plaque. He was reperfused, but lost enough muscle that his ejection fraction fell to 35%. That dropped his cardiac output, which activated the hormonal and sympathetic systems, which added afterload and volume he could not handle, so he developed left-sided heart failure. He was diuresed, which dropped his potassium and magnesium, which destabilized his conduction and gave him ventricular tachycardia. He was cardioverted and replaced. And when he later became hypotensive with crackles and jugular venous distension, the answer was not fluid, because his tank was full and his pump was the problem. Every one of those steps came from the frame in Chapter 1. That is the entire design of cardiology. Chapter 10, Put it together. Everything in this video collapses into 6 questions, and they are the same 6 the next generation NCLEX is built on. What is happening? Recognize the cues. Why is it happening? Analyze them. Which finding matters most? Prioritize. What could I do? Generate solutions. What do I do first? Take action. And did it work? Evaluate outcomes. That last one is the step students skip most, and it is the one the exam has started asking about the most. Giving the right intervention is half the item. Knowing what would tell you it worked is the other half. One last case, and this one is unfamiliar on purpose. A 74-year-old woman, 3 days after a hip replacement, suddenly cannot catch her breath. Heart rate 124, blood pressure 96/58, respiratory rate 30, oxygen saturation 88% on room air. Her right calf is swollen and tender, the left is not. Her lungs are clear, her neck veins are distended. Take a moment with that, because notice what this is not. Clear lungs rules out the picture we built in Chapter 4. Walk the 6. What is happening? Sudden shortness of breath, low oxygen, fast heart rate, and low pressure in a postoperative patient with a unilateral swollen calf. Why? A swollen calf after orthopedic surgery is a deep vein thrombosis, and sudden shortness of breath with low oxygen means it has moved to the lungs. This is a pulmonary embolism. Which matters most? The saturation of 88. That is, airway and breathing, and it is failing now. What first? Oxygen and sit her upright, then get the provider and the piece that connects it to this whole video. Why are the neck veins distended when the lungs are clear? Because a large embolism blocks flow through the lungs, so the right ventricle is suddenly pushing against enormous resistance and backs up into the body's veins. That is obstructive shock, the 4th quadrant from Chapter 9. Full tank, working pump, blocked path. And it is exactly why a fluid bolus is not the answer here either. If you retain 5 things from this video, make them these. 1. Cardiac output is rate times stroke volume, and stroke volume is preload, afterload, and contractility. 2. Left failure backs into the lungs, right failure backs into the body. 3. Troponin tells you if muscle died, the ECG tells you if the artery is fully blocked. 4. No pulse means defibrillate, a pulse with instability means synchronized cardioversion, and only VFib and pulseless VTAC are shockable. 5. Hypotension does not automatically mean give fluid. Look at the lungs and the neck veins first. And back to where we started. Heart rate 132, blood pressure 82/48. Saturation 88, crushing chest pressure. You had no idea what to do with that at the start. Answer it now. What is happening, and which order would you question? Acute coronary syndrome with hemodynamic compromise. First actions: oxygen for the low saturation, a 12 lead within 10 minutes, aspirin chewed, IV access and monitoring. And given a systolic of 82, you are questioning nitroglycerin, not giving it. Same 15 seconds of information, completely different nurse. That is the whole point. That is cardiology. Not as a list of diseases, but as one system with 4 variables and a handful of ways to break. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me in the comments which system you want built next. Educational content only, not medical advice. Go be the nurse who knows what is happening.